This week, we are going to learn all about public health communications. We're going to learn theories, planning, application, models, because no matter what you do in public health, it's going to require you to communicate it with somebody, and you need to do so in a way that is easy for them to understand. This could be other stakeholders, other agencies, or even members of your community. Public health communication is different from most other communication or any other kind of training that you might have received. It's usually not an argument, or we don't develop arguments, or even a standard essay that we might be used to. Communication in public health is the study and use of communication strategies to inform and influence individual and community decisions that enhance health. So the first difference is that we always focus on health. The second major difference is the use of strategies to inform and influence decisions. And as you might be aware, this can actually be very difficult. Communication scholars actually trace the origins of the study of rhetoric, persuasive speaking, to Plato and Aristotle. And journalism has been taught in the United States since the early 1900s. Health communication, however, is a relatively new and young field. It actually is thought to have been started in the 1950s. In contrast, the health promotion branch grew out of the communication field's longtime focus on media in communication and was concerned with the development, implementation, and evaluation of persuasive health communication campaigns to prevent major health risks and promote public health. In 1993, the director of the Centers for Disease Control and Prevention formalized the agency's definition of health communication as the crafting and delivery of messages and strategies based on consumer research to promote the health of individuals and communities. The definition characterized the public as consumers, whom agency staff needed to understand in order to serve. It also clarified the role of health communication at the CDC as not only providing information, but also working with the public as partners in prevention. There were three items that were recognized by the CDC in terms of goals: to recognize the central role played by health communication in prevention and behavior change programs, to integrate marketing and communication considerations into public planning and design, to provide staff with sufficient training and technical assistance to manage programs of this nature. The CDC sequence for health communication can be simplified into collecting and analyzing data to identify health problems and behavioral or environmental antecedents, to develop communication strategies to modify behavior or modify behavioral antecedents, to evaluate to see if the communication strategies were effective in changing behavior, recollect and analyze health data to measure health outcomes, and continue to repeat this cycle as needed. All this work did lead up to the CDC developing techniques in persuasive communication. Persuasive communication is actually exactly what it sounds. It's the act of influencing people to change their beliefs, values, or behaviors through a message. It can be delivered through written, audio, visual, or visual media. There are some tips for communication that you should, in general, consider. Your audience, consider the types of visuals you use, always be genuine, and consider the consequences of giving the message. We're going to talk a little bit about the theories of persuasion. When we talk about theories of persuasion, we need to first consider framing. Framing a message is giving it a context or even suggesting a point of view or an interpretation with which it is to be understood. Whether consciously or unconsciously, even as we speak, we frame information to make it more interesting, more palatable, or more frightening for our audience. The frame itself has been demonstrated to have a direct impact on how someone hears, processes, and acts on the information. As such, it is an important technique for persuasive health communication in addition to advocacy and politics. When we talk about persuasion and framing, we need to understand that there's two different ways to frame things. Uh, Gain framed appeals state the advantages of taking the action, such as you're 20% more likely to win if you buy 4 lottery tickets. Lost framed appeals state the disadvantages of not taking the action, such as you are 80% more likely to lose if you don't buy 4 lottery tickets. Some research suggests that game framed appeals are more effective for promoting prevention behaviors and health maintenance, such as wearing sunscreen to prevent skin cancer. Lost framed appeals seem more effective to promote detection behaviors for illness, such as performing self breast exams to detect lumps. The concept of social marketing is the design, implementation, and the control of programs aimed at increasing the acceptability of an idea or a practice or product in one or more groups of target adopters. The process actively involves the target population who voluntarily exchanges their time and attention for help in meeting their needs as they perceive them. Audience segmentation is dividing something large into smaller pieces, such as an orange broken into slices. While we would like to help everyone who is affected by a particular health problem by providing everyone with the same prevention information, a one-size-fits-all is not usually an approach that will work and it doesn't really work in public health at all. We will be more effective if we can reach and speak to a particular group of people who are likely to be interested in what we have to say in the first place. There are different considerations in terms of segmenting our audience. Many health communication segmentation strategies are often limited by a budget. As a result, partner-based segmentation, that is working through intermediary groups who have the desired target audience in their constituency, is commonly used to simplify logistics and reduce cost. For the same reasons, channel segmentation based on personal media preferences is extremely popular. Since the expansion of the internet, the potential for channel segmentation has increased dramatically. For maximum impact, most programs use behavioral readiness or psychosocial indicators to create segments. Because of this, local health departments and other public health agencies might be working with other government agencies to access some of the tools for communication with different audience segments. Targeting means to focus on one small group of people within a larger population that has critical features in common, whereas tailoring is referring to communications that are directed to an individual based on individually collected information. These may be mass distributed, but they should still reflect individual interests and do not make the assumption that all birds of a feather flock together. An, an absolute must from marketing to health communication field is the central position of a consumer's perspective of a product or a service. Remember, our public here and our population is our consumer. They're going to be using our goods and services, so we need to make sure that we keep them in mind when we do anything. When we talk about a product's attributes, which are created by the manufacturer, they're not equivalent to the benefits of the product as perceived by the consumer. So this is very important for us to understand. An example is toothpaste marketers do not promote the chemical compounds making up their toothpaste minty flavors. They promote the benefits of fresh breath directly to sex appeal indirectly. So, made of some combination of oil, surfactants, and perfume, is marketed as a product that makes your skin soft and smooth, makes you smell nice, and yes, it makes you look more appealing to the opposite sex. It is the benefits of a product, service, or idea, not the chemical composition, that must outweigh the barriers to the product's use or compete with something else being used in its place. The private sector has learned to ask the consumer about what he or she wants or likes in a product, and public health communicators should actually do the same. Most barriers, like benefits, are in the mind of the consumer. The economic concept of price elasticity of demand makes the point that barriers are not universal, nor are they necessarily stable for an individual. Cost is often seen as the most important barrier to acquisition of a product. But in fact, if consumers value a product sufficiently, they will pay just about any price for it. We also need to consider doer versus non-doer. When we talk about doer versus non-doer, we are asking those who already are using the desired product or performing the desired behavior about their choice. They are the doers. This will then help us determine how we can better get a desired outcome from the non-doers. Additionally, the fields of marketing and social marketing are large and have a lot of research behind them. So I highly recommend and suggest that if you're looking for particular help on communicating your health program or something that your health agency is wanting assistance in communicating on, look at the research, because it's likely that somebody else in public health has already tried to market something similar. We are going to talk briefly about some of the behavior change theories that we find in communication that may help us with communicating or marketing a health program in our population. We're just going to talk about these briefly because there are other modules where we go more in depth to these, but I just wanted to highlight some theories that are used in communication aspects. The first is the health belief model, which was one of the first in the field of public health to explain individual health behaviors, particularly individual decisions to participate in public health services such as free TB screening programs. In HBM, there are several sets of beliefs that either motivate or discourage people on certain behaviors. You have your perceived susceptibility, your sense of personal risk for a health condition, your perceived severity, your belief about how serious the condition is, perceived benefits of intervention, your perception of the effectiveness of taking action, perceived barriers or costs of intervention, your perception about how expensive everything actually is, cues to activate behavior change, and then also self-efficacy to perform the behavior yourself. The trans-theoretical model, TTM, also is actually known as the stage of change model, which indicates that individuals move through a specific process when deciding to change their behavior and then actually changing their behavior. These phases are pre-contemplation, contemplation, preparation, action, and maintenance. Different individuals may be at different stages along this process and thus must receive different tailored interventions or communication according to their attitudes. An example is that smokers who are not in pre-contemplation have no intention of quitting smoking in the next 6 months. So information about cessation aids, such as nicotine patches, won't actually help them. The precaution adoption process model, which is PAPM, looks quite similar to TTM in that it consists of distinct stages between a lack of awareness and completed preventative action. According to the originators of the stage, these are unaware of the issue, aware of the issue but not personally engaged, engaged in deciding what to do, planning to act but not yet acting, deciding not to act, acting, and maintenance. This model asserts that these stages represent qualitatively distinct patterns of behavior, beliefs, and experience, that the factors that produce transitions between stages vary depending on the specific transition being considered. Social cognitive theory hypothesizes that individual behavior is the result of constant interaction between an external environment and an internal psychosocial characteristic and perceptions from the person. This idea has been dubbed the reciprocal determinism. There are many constructs included in this model Self-efficacy, I can do it, is one of them and has become an in and of itself for many behavior change interventions. The integrative model represents an evolved versions of the theory of reasoned action. The most important assumptions of this model is that the best predictor of behavior is the intention to perform the behavior. This model focuses on the antecedents or predictors of an individual's intention to perform or not perform a behavior. The beliefs are behavioral beliefs are expectancies about positive or negative outcomes related to performing the behavior, which leads to the formation of attitudes. Normative beliefs are perceptions about what relevant others think about performing the behavior or beliefs about what others are doing. Together, these beliefs determine a concept of perceived normative pressure related to the behavior. The diffusion of interventions addresses change in a group. It can be a classroom, organization, or community. The theory describes how new ideas or innovations are spread within and among people, organizations, and communities. A lot of times when we are developing or thinking about our communication approach to a population, we actually want to have a strategy or do research to develop the best communication to make sure that we get our population where they want to go. Formative research refers to information gathering activities that you conduct prior to developing a health communication strategies. We usually try to invite representatives of the target audience because they actually have to guide concepts, messages, and materials, as well as the choice of media channels, because this will give our intervention the best chance of success. Formative research is done to develop an intervention. You may use both quantitative and qualitative methods to accomplish the goal. Quantitative epidemiological data or behavioral survey results are numbers. This involves classifying and counting. An example of this is how many children are obese. It's largely used to identify problems and precursors prior to the intervention and to evaluate the impact of communication interventions. Qualitative research, on the other hand, provides the backstory for the quantitative data and may point to the need for more quantitative studies. An example of this is asking many individuals or small groups with children why they hate exercising. You might learn that they feel ashamed, or you might learn something else that might help you tailor your intervention to meet their needs better. There's also mixed methods, which is a combination of quantitative and qualitative approaches. Although baseline evaluation and formative research are both implemented in the early phase of an intervention and may even be conducted simultaneously, they actually differ in magnitude and goals. Evaluation designs typically analyze a large number of samples and carefully control for confounding factors in order to detect significant intervention effects. Formative research, on the other hand, usually collects in-depth information from smaller groups of people with a view toward improving the design strategy for a planned intervention. Sometimes it is efficient to mix both of these methods. An example is if you have an informed consent protocol and it allows you to ask a person during an in-person or a telephone survey if you may contact them again for follow-up questions or an in-depth interview. The Behave framework actually provides 4 deceptively simple questions that should be answered wherever we're doing communication and working with groups of the public. We always need to consider who we are trying to reach, what we want them to do, what factors influence their behavior, and which actions will most effectively address these factors. We also need to consider our audiences. There are primary audiences and secondary audiences. And the primary audience is the group of people whose behavior you hope to influence through a communication intervention or an intervention that you're working on communications for. A secondary audience or a tertiary audience is people that can be used or leveraged to reach our primary audience. So these might be people that are considered gatekeepers, like health professionals in a particular community. We may actually want to tailor or target our communication to these individuals because they may have to put the intervention into place for our community to follow through with. We also need to consider the behavior that we need to change. We need to identify what that behavior is. We like to think of, we need to identify what this behavior is and then work through any remaining steps that may need to be taken by the population to then implement the behavior. This is called the behavioral lever. Health promoters need to know exactly which steps of a behavior they are trying to change and what factors can be used to predispose, enable, or reinforce that step. When we talk about communication interventions, there's a few concepts that we probably need to understand. The first is settings. This includes places where either the audience will need to go to make contact with the communication, or places where the media can be brought to them. The time aspect is very important because a place that seems like a good setting for your audience might be impractical if they will not be attentive to your message. It's actually easy to confuse settings with channels. We can think of our home as a setting. There are many media channels that can come into our home. This could be the mail, it could be the internet, it could be television, radio, or phone calls. These are all channels, but these channels can also be received in other settings, like the public library. Interpersonal channels and groups include healthcare providers, clergy, teachers, and others who will interact with the intended recipient in person. The strength of interpersonal channels is that people tend to trust the spokesperson and will possibly be ready to listen to what they have to say. Organizational and community channels are similar to other group communication channels. There is more formality and structure here, though, when dealing with business organizations, involuntary agencies, or religious groups. They can be a very effective partner for disseminating advocacy messages or health communication if it's not too detailed. Mass media is media that reaches large populations, either individually or in huge markets, and have become more diverse in recent years. Typically, scientists learn a method or two in graduate school and then continue that method throughout their research careers. Social and public health scientists are actually no exception. Some of the things that we might do as public health professionals include the following research methods. This could be anthropological methods. Anthropologists study health behavior in its cultural context. Their work contains a richness necessary to begin developing hypotheses about behavioral antecedents and what might prompt behavior change. Ethnography is the study of a group of people and their life ways, typically over a long period of time. This term is used to describe what cultural anthropologists do and the body of research that they produce. Now, rather than taking years to research a problem, many programs have anthropologists train community members to conduct the research in a much shorter time. Behavioral observations can also be made by healthcare practitioners, by public health practitioners. Most health marketing programs attempt to change a behavior, which is an important place to start in observing the behavior in a setting where it is practiced. Sending trained observers into homes and communities to watch what is going on might actually help inform changes that you might need to make in your intervention or your communication plan. People are much more comfortable talking about what they do than having someone watch them do it. So in-depth interviews are sometimes used to discuss highly personal topics, and usually at a stage of research where the program does not yet feel sufficiently informed to use a group format. We can also interview key informants. These are gatekeepers. These informants work with members of the community or influence them in some way, and hence have a great deal of pertinent information to share. Ethno-linguistic techniques have been popularized, just like other rapid ethnographic tools, as a quick way of understanding how another group of people organizes their world into different cognitive categories. Free listing is when a respondent is asked to list out all examples of a particular kind of thing that they know about. And pile sorting is when you need to have an individual respond and sort the cards into piles or groups. You might also ask people to rank order a specific category. An example of this is flu symptoms, most unpleasant to least pleasant, life partner qualities, most important to least important, or breakfast food, most favorite to least favorite. Focus groups, you really give us a feeling for what people think, feel, and say they do. Focus group discussions are useful in developing hypotheses, exploring broad topics, and producing a large number of ideas. Maybe even more than focus groups, social marketers love central location intercept interviews. The researcher goes to a location where the intended audience would encounter information about a behavior or acquire a product, and then invites the audience to participate in an interview. Shopping malls were actually used extensively in the United States for this kind of research. A doer versus non-doer study is an overall approach to organizing your formative research, and you might be able to implement it using some data collection techniques that we've already learned about. There are 7 steps in the process when we think about doing this type of research. The first is that we need to clarify the behavioral goal. The second is that we have to define the behavior and the audience. The third is to determine how you will distinguish the doers from the non-doers, because we need to put the entire population into 2 groups: the people that are actually doing the behavior, or the people that are actually not doing the behavior. From there, we have to develop attitude questions. There are suggestions to get some of these attitude questions. You can ask what people see as the advantages or good things about the intervention. You can ask about what the disadvantages or bad things are. For current doers, we might ask them to think back about the decision that they made. Or when we're talking to non-doers, we might want them to compare the good and bad of doing a specific behavior. Then, after that, we organize all the data that we've collected, and we look at the results after that. In this step, you review all the answers and then list and count up all the responses for the question. It's facilitated by using a coding sheet or sometimes some software like Excel. You will have lists organized by doers and non-doers with the most frequently mentioned answers at the top. From here, we interpret the results. Some of the tips for the doer versus non-doer analysis is if doers and non-doers have a similar percentage for any item, the item is not likely determinant of the behavior. When doers' responses are radically different from a non-doer's response, the item is very likely to be a determinant of behavior change. This is the reference that was used to provide this slide deck.